Hey there, class. Today we're diving into a condition that sounds like a spelling bee nightmare, but is all too familiar on the Med-Surg floor. Tonsillitis and adenoiditis. Whether you're caring for kids, teens, or adults who still hold a grudge against their tonsils, this one's worth knowing front to back. What are tonsils and adenoids? Tonsils are clusters of lymphatic tissue located on either side of the oropharynx. Specifically, the phautial or palatine tonsils are tucked behind the pillars of the fauces, and the lingual tonsils hang out at the base of the tongue. These guys are frontline defenders in the immune system, but they're also repeat offenders when it comes to infection, and that's where tonsillitis steps in. Tonsillitis can be acute or chronic. Acute tonsillitis often looks like pharyngitis. Chronic tonsillitis is less common but trickier to diagnose, sometimes mimicking allergy, asthma, or rhinosinusitis. Now let's talk adenoids, also known as the pharyngeal tonsils. These are located in the center of the posterior wall of the nasopharynx. When adenoids are infected, we call it adenoiditis, and it often goes hand in hand with acute tonsillitis. Common causes. For bacterial causes, the heavyweight champ is Group A beta hemolytic streptococcus, GAHS. As for viruses, the most common culprit is Epstein-Barr virus. Cytomegalovirus can also trigger tonsillitis and adenoiditis. And while we often think of this as a childhood issue, don't forget, tonsillitis can occur in adults too. Signs and symptoms. So what does tonsillitis feel like? Let's break it down. Sore throat, fever, snoring, difficulty swallowing. If adenoids are involved, the list gets longer. Mouth breathing, ear pain or drainage, frequent colds, bronchitis, foul-smelling breath, voice changes, noisy breathing. When adenoids are severely enlarged, they can block airflow from the nose to the throat, causing nasal obstruction. Worse, the infection can spread to the middle ear via the eustachian tubes, leading to acute otitis media. This can cause ruptured eardrums or progress into mastoiditis, an infection of the mastoid bone. And if it simmers in the background long enough, it can lead to chronic hearing loss. Diagnosis and assessment. Diagnosis is mostly clinical. Your provider will look at the throat, check symptoms, and determine whether it's viral or bacterial. The rapid antigen detection test, RAT-T, is quick and convenient, but less sensitive than a throat culture. In suspected viral cases, especially cytomegalovirus, you want to rule out other illnesses like HIV, hepatitis A, or rubella. If adenoiditis leads to hearing loss, especially from recurring ear infections, a comprehensive audiometric assessment is recommended. Treatment options. Treatment for tonsillitis depends on the cause. If it's viral, we stick with supportive care. Rest, fluids, saltwater gargles, maybe some antispasmodics for comfort. If it's bacterial, penicillin is the first-line antibiotic. If they can't take penicillin, then cephalosporins may be used. Surgical management. Here comes the classic childhood rite of passage, the tonsillectomy. This may be done with or without adenoidectomy. It's the go-to treatment for chronic tonsillitis and repeated infections that don't respond to antibiotics. Tonsillectomy is indicated if the patient has recurrent tonsillitis, obstructive sleep apnea due to enlarged tonsils, recurrent purulent otitis media, suspected hearing loss tied to enlarged adenoids, a paratonsillar abscess that makes swallowing hard and blocks the airway, tonsillar asymmetry, which may signal lymphoma. In that case, a biopsy is needed. Patients may be placed on oral penicillin or cephalosporins like ceftonir or moxifloxacin around the time of surgery. Right after surgery, continuous nursing observation is key because the biggest risks are bleeding and airway compromise. The most comfortable position? Prone, with the head turned to the side so drainage can come out safely. Hold off on removing the oral airway until the gag and swallow reflexes return. Nursing interventions include ice collar to the neck, basin and tissues ready for any blood or mucus, pain control using analgesics. If the patient coughs up bright red blood, that's concerning. If they swallow blood, it may appear as brown vomit later. Other warning signs: increased pulse, fever, restlessness. Call the surgeon immediately. You'll need a light, mirror, gauze, curved hemostats, and a basin ready in case the site needs to be checked for bleeding. Sometimes the bleeding requires surgical religation under general anesthesia. If there's no bleeding, you can start with water and ice chips and then slowly reintroduce soft foods. Patients should avoid talking, coughing, and hard or spicy foods. All of these irritate the throat. Teaching patients and families. These procedures are usually done outpatient, so education is critical. The patient should be awake, able to drink fluids, able to void before discharge. Teach them the signs of hemorrhage, which may occur up to 8 days after surgery. For pain, liquid acetaminophen with or without codeine is fine. Encourage soft foods, good hydration, alkaline mouthwash or warm saline rinses, use of a cool mist humidifier, completion of any prescribed antibiotics. Caution them to avoid hot, spicy, or rough foods, gargling or brushing too vigorously, smoking, heavy lifting for at least 10 days. Also reassure them that a sore throat, mild ear pain, stiff neck, or a little vomiting can happen within the first day.